So to further our insights into the topic on closing the gap in maternal and child health disparities, we now invite Dr. Marisa Domino, who will present on do longer lengths of postpartum coverage allow an earlier start to treatment? Results from North Carolina Medicaid. Marisa Domino joined the College of Health Solutions in January of 2022 as a professor and the director of the Center for Health Information and Research, the college's multidisciplinary unit that serves and collaborates with individuals and organizations that need comprehensive health information and data analysis for public, private, and research uses. Dr. Domino earned her PhD in health economics from the Johns Hopkins University and completed a postdoctoral fellowship at Harvard Medical School's Department of Healthcare Policy. She has decades of experience analyzing Medicaid and other health policies using advanced economic metric and statistical techniques. Her research generally focuses on individuals with mental illness, substance use disorders, or other chronic conditions. So please join me in welcoming Dr. Marisa Domino.
Thank you so much, Natalie. I appreciate that introduction. Hi, everybody. Marisa Domino. As Natalie indicated, I'm a professor here in the College of Health Solutions at ASU, and I run a big data center called CHEER, Center for Health Information and Research. And so I'm actually going to talk to you today about some work that I've done in my prior life. Then before coming here, I was at the University of North Carolina, and there we had a contract to do an evaluation of North Carolina's Medicaid transformation. And so that's still a project I co-lead. And, I thought this would be actually a good presentation to show because we can do exactly the same thing here in Arizona. And so forgive the departure into North Carolina a little bit, but I think I'll try to bring it back to the relevancy in Arizona. So as Natalie said, we're going to talk about whether longer lengths of coverage allow for an earlier start to treatment and sharing results from North Carolina Medicaid. And I want to first acknowledge my co-authors. So Dr. Jonas Swartz is an OBGYN at Duke. Kate Bundorf is a health economist at Duke. And Ashley Avis is our data scientist at the University of North Carolina. And this is a project that was supported by North Carolina's Division of Health Benefits. Okay, so I think Rashini's talk was a fantastic setup to this talk because she did talk about the importance of health insurance in reducing maternal mortality. And so we're looking at that piece of the puzzle. And so Medicaid, which is a federal state partnership, pays for about 41% of the births in the United States. And you can see that varies a little bit by state. And Arizona is out here with a higher than average rate, 43 to 61%. And the state I'm talking about is North Carolina, which has, just about an average rate of Medicaid coverage. And so Medicaid, although it seems like one program, it's actually many programs rolled into one, often with different benefit designs, different provider networks, things like that. So I'm going to unpack that a little bit in the context of pregnant people. So state Medicaid programs must cover pregnant people. There's a federal regulation with incomes up to 138% of the federal poverty level. And that's a specific Medicaid program that used to be called Medicaid for Pregnant Women. I'll use the acronym MPW. So many states have chosen to increase the income limit there so that they can cover more pregnant people. And, on the high end, some states have allowed that as high as 380% of the federal poverty level, which is an income threshold that's adjusted for the number of people in the household. However, that's not the only path to Medicaid coverage. So it's one I'm going to talk most about, but just to be clear, there are other ways that Medicaid covers pregnancy, birth, delivery, as well as postpartum care. So many births are covered through the MPW as well as other federally mandated categories. There are people receiving supplemental security income who are entitled to Medicaid, people who are blind or disabled, in addition to MPW. So we know that those groups have other paths to coverage. So historically, and by historically, I mean before the pandemic, the length of coverage for MPW enrollees was limited to 60 days postpartum. It's a little bit variable, which is why I have the approximately 60-day symbol there, because in most states it's implemented as the end of the month in which 60 days after delivery falls. So for people who delivered early in the month, they actually have greater coverage than people who delivered later in the month. And so little has been known about what what happens when those 60 days are up? So we don't know much about the extent to which maybe, people who deliver through MPW might have changes in, their household characteristics and might now qualify for other Medicaid programs, or how many people lose coverage. And so that's one thing that we look at here. We also look at the content of what happens either during those 60 days, or as I'll talk about, there's situations where the postpartum coverage has been extended. So I think, this is where I think Roshini's talk is particularly important. So we know that having coverage at a minimum for 60 days postpartum is really important, and in fact longer if possible, because 60 days is a very short time period after giving birth. That's a time period where many people still have ongoing healthcare needs that don't stop after 60 days. And we know from other research, for example, the expansion of Medicaid that happened in a lot of states through the Affordable Care Act found that extended coverage is associated with, decreased uninsurance, obviously, and increased utilization of care for postpartum Medicaid beneficiaries. So there was one study that showed a reduction in maternal mortality of about 7% per 100,000 live births overall, and 16 per 100,000 live births among Black birthing people associated with ACA expansion. So, this can definitely be one of the mechanisms that can help address the maternal mortality crisis that Dr. Naidush discussed. So prior to the pandemic, people who were enrolled in Medicaid through the MPW pathway only had 60 days coverage postpartum. Their coverage would start whenever their pregnancy was confirmed and they applied to the Medicaid program. And so usually they would start coverage right away. But, for some people that was late in the prenatal period, and for others it was earlier. So the variable lengths of coverage during the prenatal period. But what happened during the COVID public health emergency is that, as you know, Congress passed a moratorium on disenrollment from Medicaid. So that actually allowed people to have a longer length of coverage, because people who gave birth, actually even just before the pandemic started, were given this much longer time period of Medicaid coverage. And that moratorium on disenrollment actually just ended at the end of March last year, when the unwinding of Medicaid began. And so this has meant that people enrolled in the MPW program had different lengths of coverage during the pandemic, depending on the timing of births. So if they gave birth in early 2020, they ended up having greater than 3 years of coverage. But in theory, births towards the end of the pandemic went back to the 2-month coverage period. I'll give you a very important exception to that. So during the pandemic, there was actually the American Rescue Plan of 2021, which allowed states to implement extended coverage up to 12 months postpartum. And that opportunity began on April 1, 2022, although not all states took up on that date. So North Carolina, what I'm going to talk about, actually was one of the first states to implement the extended postpartum coverage to 12 months. Arizona did so just recently, so last April 6th of 2023. So a year later than North Carolina. So maybe the data that I'm showing will, have sort of similar implications for Arizona as it did for North Carolina. But you can see by now, most of the states are blue here. So 46 states have now, well, at least as of March 8th, have now implemented the postpartum extension. Okay, so what's the importance of expanded coverage? So obviously having a source of payment for health needs is super important, and it provided an additional 10 months of coverage. But the difference we think of between the extension time period, where people were given a guaranteed 12 months of coverage, versus the pandemic time period, which for some people was longer than 12 months, but nobody had any idea during that time period when coverage was going to last for. So we don't know, if you gave birth in January 2020, you just knew that they weren't going to disenroll you for now. And as you might remember, there were many time periods where there were proposed ending of the public health emergency, and it kept getting extended and extended. So people really didn't know how long their coverage was going to last for during the public health emergency. So we have one extension with certainty, and we have one extension that had considerable uncertainty. And you might imagine that, one of two things could have happened with extended coverage. So one is, if you have a condition, maybe a mental health or substance use disorder, maybe other physical health conditions that, are not going to be fixed in one visit. On the one hand, having an extended coverage might allow you to actually initiate care because you know you're going to have coverage to maybe go through a whole episode of care. And so it may have allowed for earlier initiation of services. On the other hand, we know that, if you thought you had 60 days of coverage and it was extended for a year, that first 60 days post-birth is a very busy time for people, and it's often hard to initiate services during that time period. And so it could have allowed people, the comfort of being able to initiate certain kinds of care after that time period. So, it's sort of an unknown theoretically about, what's going to happen during that 60-day time period if there's an extension. Could more things happen because people have adequate time to deal with them, or would people put it off until, life has settled down a little bit? And so that's one of the things we wanted to understand. So using data from North Carolina, and again, we have very similar data in CHEER, and so I'm happy to talk with anybody maybe interested in doing similar kinds of work here. We looked at what happened when the postpartum coverage was expanded, and in North Carolina, again, that was April 1, 2022. And so we wanted to look at enrollment trends and utilization under the shorter eligibility period prior to COVID, in addition to the longer eligibility periods with more time of coverage, and then just see what that longer insurance coverage period, how it affected the use of certain services. So services like postpartum care, contraceptive care, primary care, mental health care, and substance use care. Okay, so here's a little bit about the data. So we have North Carolina Medicaid data. We know, exactly when people are enrolled in Medicaid, what program they're enrolled through. We have the claims and encounter data, so we can track all Medicaid covered services. We started our time period 3 years before the PHE went through July 2023. As those of you who may have used Medicaid or other claims data know, there's a sort of a lag period. So we don't want to go right up to today because, it takes sometimes claims a while to be reported. So we've stopped it this last summer. And we include birthing people ages 14 to 48 who are enrolled in Medicaid and had a Medicaid funded birth during this time period. And so we defined 3 cohorts: birth prior to the PHE, birth during the PHE, but before the extension. So that was through March 2022, and then the extension time period. And again, both of the second and third groups had at least 12-month coverage, but only the third group knew that they were going to have 12 months of coverage. And we do, because there's a little bit of right censoring going on because of these time periods. We keep people in the study for sub periods, even if we don't have a full 1 year of follow-up. I said we looked at coverage patterns for these cohorts. We're looking at utilization of services during those first 60 days. For the pre-PHE cohort, we don't see what happens to them if they're not covered by Medicaid anymore. So I can't tell what percent, for example, had a postpartum visit after 60 days because my lens of using Medicaid data only allows me to see the things that Medicaid funded. So unfortunately, that's kind of a big piece that we wish we had, was more information on what happened to that first group after their 60 days were up. And then we look at multivariate models, to try to tease out the effect of some of the covariates, and I'll present some of those results. So this is what our sample looks like. We had about 350 people who gave birth on covered by North Carolina Medicaid during this time period, broke down by, the 3 cohorts that I mentioned. You can see the extension cohort is smallest because we have the shortest time period there. And, everything is statistically significant, which happens with big data sets. But if you look at the results, they're really not practically significant. So again, age went from just under 27, age at birth, to just over 27 years. So, the statistical tests find, because of the large sample sizes, that those are different from one another, but for the most part, not a lot changed across these cohorts. Maybe a couple notable things are that the second to last row, when we looked at mental health diagnoses during pregnancy, the pre-PHE cohort, about 18% had at least one mental health diagnosis during the prenatal time period, and that went up to almost 22% in the extension. Substance use disorder diagnoses, just under 10% in the pre-PHE cohort, went to just over 10% in the PHE and extension. So both of those were increasing a little bit during this time period. Okay, when we look at coverage at birth, this is what the distribution looks like. So just the blue bar is full Medicaid, which means not Medicaid for pregnant women. In some states, Medicaid for pregnant women is a more restricted set of benefits that only relate to maternity-related care. In North Carolina, they allow the full set of benefits to be given to people, with MPW coverage. So that is, they basically say everything is related, and so we'll cover all kinds of services. So, a foot fracture or something like that would be covered in North Carolina. That's not necessarily so in all states, but just over half of the births were covered by full Medicaid. The orange bar is in the middle is what I'm going to focus on. That's the MPW group, and that's about 30%. And then the remaining 10% or so is what's called emergency Medicaid, which provides reimbursement to the hospital for care, but does not confer any healthcare coverage, either prenatally or postpartum. So that's, I think, a different talk because, that's clearly a small but not trivial percent of births. Okay, so when we look at enrollment over time, let me explain how this works. So each of the 3 cohorts are represented in each of the 4 sets of bars. So at birth, at delivery, the 100%, all 3 bars are blue because that, showing that by definition, these are people who are covered by MPW coverage. By 2 months postpartum, the second set of bars here, most people in the pre-PHE cohort were still on MPW. So this is where the 60 days, for the most part, it covers 2 months. Some people had rolled off onto full Medicaid, possibly because of other life-changing events or diagnoses that allowed them to qualify. There's a waiver in North Carolina, which is this tiny green bar, which gets a lot bigger, called Be Smart, which is a contraceptive waiver. So that is people who are in that program only qualify for coverage for contraceptive care. And the coverage is very minimal. So think of that as pretty close to not being covered. And then the purple bar just means there's no evidence that they're on Medicaid during this time period. So you can see by 2 months, most people are still covered. Certainly it got better during the extension time period, as well as the PHE cohort, because a lot of them, when they started rolling off MPW, they rolled onto full Medicaid. But here's where things change. So this is 4 months postpartum. In the pre-PHE cohort, only a small percent, less than 10%, stayed on MPW coverage. And typically, because MPW only lasted for 60 days, this means that either they were pregnant again or perhaps delivered early and their coverage, was still based on the anticipated birth date. Some people rolled onto full Medicaid, and so that covered up to 30% of the population. But then the remaining, 40 or so, 45%, were only on Be Smart, so very minimal coverage. And then the purple bar means they were not on Medicaid at all. They could be privately insured. They could have moved to another state. We don't know. There's just no evidence that they were insured by Medicaid. So this is potentially 70% of the birthing population covered by MPW that were uninsured, or possibly insured on alternative mechanisms there. During the PHE, just about everybody flipped to full Medicaid because of the moratorium on disenrollment, and that's how North Carolina navigated that, just by putting everybody in full Medicaid. And then postpartum extension, people stayed on MPW because now that was allowed for 12 months. And then even 12 months after delivery, you can see the numbers are pretty similar to 4 months. So again, lots of people don't seem to be insured on Medicaid in the first cohort, but certainly are in the second and third. I'm just going to highlight a few numbers. So this is a lot of information. These are the outcomes we looked at. This is among people who had 1 year of coverage. We found that about 63% got their postpartum visit within the first 60 days. Another 4% who did not get a postpartum visit during the first 60 days got one between 3 and 6 months, and then another 1.4% got one later. So not a big percentage of people who got postpartum visits, but certainly, some got them later than for 60 days of coverage. So if people didn't change their behavior, these are people who would have been uninsured at that point and not able to get that postpartum visit. So you can kind of eyeball these contraceptive visits. We know that about a third of the population had those between the first 60 days postpartum, but an 11% didn't get contraceptive care in the first 60 days, but did in 3 to 6 months. And then 4%, got some contraceptive care in 7 to 12 months. So these are the outcomes just in the first 60 days. So pretty much that first column, but now for overall cohorts. I'm just going to skim through this really quickly. The postpartum visits, you can see declined a little bit across cohorts, and we'll talk about that. Contraceptive visits declined a little bit. Primary care visits went up a little bit across cohorts. Mental health visits went up, I think, appreciably across cohorts, as did mental health visits among beneficiaries that had a prenatal condition. So this is among anyone, so whether it's their first mental health diagnosis or not. And then the same for substance use. This is a multivariate model, so controlling for all those differences you saw in the first slide. So we do see, this is saying that in the post-PHE or the PHE cohort, there was a 5 percentage point less probability of receiving postpartum care than there was pre-PHE. So in that 60-day window, when people had extended coverage, they were less likely to get care in the first 60 days. Again, it doesn't address anything outside that 60-day window. And so we see that for postpartum and contraceptive care. Primary care visits went down a little bit during the PHE, and again, that could be COVID effects as well as, the uncertainty of the length of coverage. In the extension time period, we didn't see a change from the pre-PHE in terms of contacting primary care. We do see increases in mental health visits overall and among those that have prenatal mental health visits, and we do see increases in the postpartum extension group in substance use disorder visits, and especially among those who had a prenatal substance use disorder visit. So that obviously there's limitations. This is secondary data. We didn't get to talk to people in the study to find out more about how, that the extended coverage changed patterns of care for them. Obviously, COVID happened, and so it's not just about the coverage. There were lots of limitations in seeking care, but there was also telehealth. So these estimates do include any telehealth visits that may have happened. So in conclusion, both the public health expansion and the moratorium had considerable extensions in postpartum coverage. And we saw some interesting shifts in patterns of care. So decreases in postpartum care and contraceptive care during the first 60 days, but increases in primary care and behavioral health services during those 60 days, and lots of increases in care after the 60 days. So further research, we're going to drill down on this further. And again, would love to repeat this in Arizona, because I think that's a really interesting experiment, possibly do a 2-state study. So that is all I have. So why don't I stop there?
Thank you so much, Dr. Marisa Domino. I'm leading the Q&A session for your presentation.
Great, thanks,
If there's any questions in the chat or anybody who wants to unmute themselves. But I do have a quick question for you.
Yeah.
I appreciate what you were talking about with your data. This is data that was conducted in North Carolina, you said. I think I stepped away for a bit. So I wanted to know if there was information based on the demographics on ethnicity, race, and immigration status.
Oh, sure. So I had that early on, but we went through it very quickly. So let me see if I can pull that back up. So in North Carolina, the birthing population was about 58% white. About a third reported Black race only. So in North Carolina, you can select as many races on the Medicaid enrollment form. And so these are all individual reported race and ethnicities. About 2% Asian, Hawaiian, Pacific Islander, very small Native American population there. About 5% picked multiple races. Unfortunately, we didn't have enough capacity to tease out the different groups, because they, individually were pretty small. And we had a very low rate of people not responding with at least one race category. So we kept people in who didn't report any races as sort of a separate unknown category. And then about a fifth of the population in the sample was Hispanic or Latinx.
Thank you so much. I'm thinking going forward for what you're going to do here in Arizona. I think I heard you saying you're going to be doing something similar here. Are you going to be collecting data on those lines, or just what you guys, the demographics you have now?
We could. So in Arizona at Cheer, we have, the Medicaid claims and enrollment data. And so we could definitely repeat this study here in Arizona. And so the source data would look very similar as it would to North Carolina. Unfortunately, in Arizona, there's The way that race is self-reported in the file leads to a fair amount of missingness. So we would have a much higher rate of missing race from the Arizona data, but otherwise we could look at the same types of outcomes.
Thank you. Thank you so much.